So I'm Dr. James Hopkinson. I initially trained as a GP, qualifying in 2002. I worked as a clinical assistant in sports and exercise medicine in Nottingham with Professor Mark Batt, and when the faculty was formed, I did a CSER route to gaining my CCT, or my consultant in sports and exercise medicine. I worked at Nottingham as a consultant in sports and exercise medicine for approximately 4 or 5 years until I became chair of the local commissioning organisation, when that gave me a conflict with the trust where I worked, so I stepped away at that point. And since then, I've continued working as a GP, but I've also been in leadership roles through the iterations of commissioning organisations until last year, when I became medical director of the local medical committee. I'm also the clinical director of our local primary care network. So if I was trying to commission an SEM service, I would be really keen to be able to demonstrate value for money. And really, for value for money, it's slightly more complicated than just value. In my head, I would see value as outcome divided by cost. The challenge here is it can't cost anything, because across the country, all the ICBs are in the red, so they've got no money to spend. So to be able to actually put in a new service, we need to be able to create some money, which either means stopping doing something or doing something more cheaply. And this is really difficult. Stopping doing services is very hard. And so I think we need to possibly think wider than just the ICBs as a commissioning organisation, and start to think about where the other opportunities might lie that we can help save money. So, for example, we might be approaching other providers, local trusts, community providers. How can we bolt on and add value to their service so that we can deliver care at a lower cost for them? As a crude example, that might be a hospital who are running with locums in their orthopaedic department. And if we were to use that money being spent on locums to employ a consultant in sports and exercise medicine, can we improve the efficiency of that department, allowing the current surgeons to spend more time in theatre, which is what they usually want to do, and run a strong outpatient service alongside them? So I think there's lots of challenges to doing this, and there's no easy blueprint. It's going to be very much about understanding your local landscape, and that landscape will be different wherever we are. And the key people that I'll be trying to involve, I will be trying to talk to the commissioners to understand what their needs and local wants are. I will be reading about the local ICB strategy to understand where and when we are, the opportunities might be. I'll be trying to understand what the commissioning cycle looks like for musculoskeletal care. Usually the contracts have been awarded over a cycle of often 5 years. And if that cycle is coming up to an end, there might be an opportunity to bid for a service, or at least be involved with a provider who is bidding for that service. So I think there are opportunities. I think the landscape is changing. I think provider collaboratives are starting to happen. Providers are starting to work together to start to deliver services, as opposed to having direct commissioning services. The days of the tariff have really gone. People are not paid by units of care that are done. They're under block contracts to deliver units and numbers of care. So I think, as well as the ICBs, I'll be spending a good period of time trying to talk to the stakeholders who are the other providers, other surgeons and musculoskeletal care physicians, physiotherapists who are working with those surgeons, and also the managers of the trusts and the managers of the ICB, to understand what their thoughts and feelings are. So I think the evidence of the service we commission in Nottingham is that a large number of people could be managed in the community that previously went into the hospital, which created a potential saving. So we were able to manage people at a lower cost in the community, and being able to measure their outcomes and demonstrate that patient satisfaction and patient outcomes were at least as good and often better than going via the trust, which also brought the waiting list down, which again improves patient outcomes. It's good for the whole health economy, gets people back to work faster. There's all this sort of wider parts of health which are very difficult to measure, but they're all positives that we could put into a commissioning document. But I would say the value for money of being able to drive more and more care into the community more quickly was probably the key bits. I think one of the key things that sports and exercise medicine delivers is its breadth, and it doesn't just look at musculoskeletal medicine, which is really what we've been talking about so far. It looks at bone health, particularly activity, bone health and activity, and also exercise. And I think we haven't really managed to make huge steps into exercise medicine, but the opportunity is there and the long-term gains are there. And this is where the politics of health start to matter, because clearly if we can keep people fitter, they cost us less money in the future. The difficulty is they don't fit into our current political terms. So if I keep somebody from becoming obese and inactive, I know that we will cost those people will cost us less in the future. And over a 10 or 15 year cycle, we can probably cost that. We've got good evidence to be able to back that up. It's very, very difficult to get the government to look at those sort of longer term cycles when the next election is less than 5 years away. And I think we're being perpetually stuck in that situation. We've been trying to think about how do we bridge that gap. We know the answer. We know we need to invest in these services to keep people fit and active and healthy. We know what the outcomes are. And we can see the time bomb that's coming. We're just trapped in this world where people won't invest in those longer term projects because of the initial cost. Because for the first 5 years, let's be fair, it's a cost. There is no payback in the first 5 years. The payback will be in the future.